Good afternoon, ladies and gentlemen. I welcome you in our AES Advances in Surgery event of today. And our topic is Plasma Plus. What is the plus in bipolar surgery for BPH and non-muscle invasive bladder cancer treatment? And it's not so new to use bipolar current in the treatment of BPHs and bladder tumors. Even in 2002, Shiozawa created the bipolar resection of BPH. And on the right-hand side, we see one of the first videos which were taken at that time. The characteristic thing, what we see here, is the golden shining of the loop. And we will have to speak about what is the reason for this shining. In the last years, step by step, this technique was improved. And in 2021, on the left side, with the creation of the Plasma Plus ESG generator 410, a new generation of plasma, the Plasma Plus, was created. And we want to speak today about the clinical implications, the clinical advantages of this technique to treat. And so it's a great pleasure for me to introduce I think it's an excellent faculty for this topic. We will have first with Professor Babjuk from Czech, from the Karls University of Prague, a specialist in the bladder tumor resections. And he is also a chairman of the non-muscle invasive bladder cancer panel of the EAU guidelines. And so he's the specialist in the treatment of these tumors, and we wait for his report about the en-bloc resection of the bladder tumors. The next presentation we will hear from Dr. Mandron. He's a urologist in Paris from the Georges Pompidou University, and he's a specialist in plasma enucleation and resection of BPHs. And in the last, but not least, report, we will hear the first experiences in the day surgery, in the day case pathway for the use of Plasma Plus for the treatment of TUR-BT and TUR-P in England. Dr. Nettleton comes from the Cheltenham General Hospital from Gloucestershire in UK. So that's our faculty, that's our program, and let's start now with our event. To introduce the plasma technology, I want to tell you something about the physical and also the clinical background of this technique. First, we have to speak about plasma, and if you have seen the first slide I showed you, you found a picture from Norway with a polar light. What's a polar light and the flashlight on the left side? All this is plasma in nature. So plasma is the most abundant phase of the matter in the universe, and we can find it everywhere, and we can use it also for the technical things. What's really plasma? If you give some energy to a phase of the matter, you change this phase of the matter. Gives you energy to a solid body. Then you will get a liquid one, plus energy, a gaseous one. And give you a gas or give you an energy to a gas under certain circumstances, physical circumstances, it can be possible to ignite a plasma. It is comparable with this neon lamp on the right side. If we give energy to this neon gas, then we can ignite a plasma, and the applied energy comes from the choke. You see this. It's very, very comparable to the urology. Our choke, our energy generator is the electrosurgical generator, and he controls the applied energy, and we have to speak about this. We have two further physical circumstances. One is the temperature of the gas and the temperature around the gas, around the plasma. And also the volume of the gas plays an important role. These two features are more disturbance variables. And we have to discuss these disturbance variables to discuss how can we influence our plasma that we use. First, one myth of the loops. If we see here the shining, the golden shining of the loop that we use, it does not depend on the temperature. That is the first thing. The color of the plasma that we see is determined by the diluted ions. If you use a sodium solution on the left, it is yellow or it is golden. If you use a potassium solution, it is blue. So it had no correlation to the temperature. What happens really? If the current flows through the wire of our resection loop, then it is warmed up and some bubbles are created. And these bubbles fuse step by step. And at the end of this process, we have a vapor pocket around the loop. We have our gas, if you compare it with a lamp. And if we add here energy, a certain amount of energy, then we can ignite our plasma. And then you see the golden shining. It's a very fast process. And in this high-speed camera video, you see this process. This is a loop, a vaporization loop, and on the right-hand side you see the same process with a mushroom electrode. Step by step, the bubbles fuses, and now what its pulsation is to see if that would be a colorful video, then now the golden shining you can watch. So all this process takes about 100 milliseconds in the normal electrosurgical unit, and in this one here, this whole video takes only 8 milliseconds. It's a very fast process. That's already plasma plus. With a new electrosurgical generator, this ignition process takes only 1/10 from the old, only 8 milliseconds. And what is done here? We have our vapor pocket, and with the vapor pocket, we give to this vapor pocket an initial peak of energy. This is a high peak of 400, and with a newer electrosurgical unit, 600 watts. And this ignites the plasma. This application of energy cannot be controlled by the surgeon. It is an automatic process. And then the computer, the electrosurgical units down-regulates the real output of the energy to the absolutely necessary wattage that we need to keep the plasma working. It's about 100 or less watts, and this is what the generator gives up. So that cannot be controlled by your hands. You can select some settings, but what really the real output is not controlled by you. You can only control the maximum output. So a clear recommendation is never change the recommended settings. You cannot change what really happens. But if you go down with your threshold under a certain amount, then the computer will not work anymore and you have problems. This plasma, what is ignited, is not hot. If you see at this video, you can touch the activated plasma without burnings at the finger. It's not hot because the hot electrons moving in this plasma has no heat capacity. So we do not feel this hot, but we can vaporize cells, we can treat wounds, just like here in the lower video, and we can cut with this, but we cannot burn, we cannot carbonize the material. The second feature to be discussed was the temperature. I told you something about the temperature of the plasma itself. Important in the beginning of this era of plasma use was the temperature around the plasma, the temperature of the irrigation fluid. And you see, with a room temperature irrigation fluid, the plasma could not be ignited. With the same system and more, about 30 degrees, it worked very well. So the recommendation is today, also today, use preheated water of about 30 degrees. On the left-hand side, we see a very new resection with a plasma plus. And you see, independent on the dryness of the material, independent of the temperature of the irrigation fluid, it works. Today, there is no limitation by the temperature anymore, but it can be improved by preheated water. And the third question was, what's with the volume of the gas? The volume of the gas, as bigger the volume of the gas is, as more difficult it is to ignite the plasma. In the former ESG 400, it was recommended to use the mid-sized loop. Why? Because the mid-sized loop has a low volume of vapor pocket. And sometimes, if it's very dry material, it was necessary to touch the tissue to diminish the volume of the gas to ignite. With the newer ESG1, that's not anymore an ignition. The ignition is independent now of size and shape of the electrode, consistency or dryness of the tissue, and velocity of the resection. Nevertheless, with this new technique, you can use all sizes and all shapes of the electrodes without any touching of the tissue. The ignition of the plasma works only moving the shape or only moving the loop inside of the irrigation fluid. So it was improved. When we started with our plasma era, we thought we can significantly reduce the reaction of nerves. And you see here a resection video, and it's at the side wall, and not so far is the obturator nerve, and you see a weak reaction of the obturator nerve. But now we know what we have here is not an ideal bipolar system, it's a quasi-bipolar system. So a certain amount of the current flows through the surrounding tissue. And if we go back, and you see on the lower part on the left side, you should expect, if the obturator nerve is very closed, less than 1 or 2 centimeters, you can expect strong reactions also in these cases. So we have to be careful also with these reactions. And very interesting effect was on the left side, the so-called self-cleaning effect. If there are clotting necrosis inside, you can activate your left pedal, your vaporization or your plasma, and then this loop cleans itself. So it spares a lot of time during the long resection or the fast resections. On the right hand side, you see additional shapes of loops, the needle loop or the enucleation loop we can later speak about. And here some examples of the oval button. The oval button is very effective in vaporizing material on the right side. We start with a vaporization of a BPH. The indication can be discussed later, but it works very effective. On the left-hand side, it is used to smoothen the capsule, to smoothen or to vaporize necrotic material which is adhesive at the capsule. So also here, all electrodes are usable. On the left-hand side of this slide, you have all the commercial available electrodes. On the right-hand side, I want to, before we continue, I want to tell you something about some basic rules. Independently what you do with this plasma or with the plasma plus, bladder tumor resection, BPH enucleation, whatever, you have with your instrument, with your resection, resectoscope and your loop and multifunctional tool. You can cut with this, you can coagulate, you can vaporize, you can do a lot of things. Do it. Make your procedure as simple as possible. And if it's better to coagulate, then do it. It is better to cut or to vaporize, then do it. Minimize the energy that you apply, especially on the anatomical structures, just like the capsule. As less energy you apply, as better for the patient will be the post-operative outcome. And in all cases, respect the anatomy, save the anatomical structures. We speak today about the anatomical enucleation or anatomical resection of the TUR, and that's really important to preserve important functions for the patient. When we started with the bipolar resection, we had a small study, and these are the results of the study. It was limited for BPHs to enucleate, and it had only 60 grams, and what we saw was, if we do an excellent resection with bipolar or monopolar, the results according to the micturition parameter are very, very similar. But with the bipolar one, we saw additional advantages. One of these advantages was a reduced blood loss. Intraoperative, we had a significantly reduced blood loss only with a bipolar resection, not enucleation, resection. And this is a study by Fagerström. He could say, or he could show with a low hemoglobin photometer measurement the real-time blood loss during a TUR-P. And he could show it is really significant that we can reduce the blood loss. This is a study from India. This study showed us, and it was also our imagine, that if we use a bipolar current, the post-operative outcome is better. The post-operative dysuria or the post-operative urge symptoms are weaker than with the monopolar one. We thought about these problems, and I think there are two reasons of this post-operative urge. One is, one reason is very important. The amount of necrotic material inside of the prostatic fossa is important for the post-operative urge. And the volume of the necrotic material inside of the fossa depends on of course, the completeness of the resection. If you remove all material of the BPH from the fossa, that's very well. And of the depth of the necrotic zone. And the depth of the necrotic zone depends on the applied energy. And we had a look at the international reports, and we found a wide range of descripted depths of the necrotic zones using bipolar current. And nobody knew, or nobody did real studies. It was only descriptions. So we decided to make a prospective randomized study with 60 patients, 240 specimens, and it was recently published in the Asian Journal of Urology and is in press now. And we found a necrotic depth independently of the electrode, loop or button of 0.05 millimeters. It's a very, very flat necrotic zone. If we compare it on the right side with the necrotic zone of the laser, you see here KTP is the green light laser, 0.8 millimeters, diode laser, till 5 millimeters. Also thulium and holmium yak, 0.2 millimeters. So we have the energy with the plasma plus or plasma with the flattest necrotic zone after resection or vaporization. And so we should expect the best postoperative outcome. Here is a patient, we did an enucleation and resection with plasma, and 10 weeks later, because of an incidental carcinoma, we did a radical laparoscopic radical prostatectomy with nerve sparing, and we saw no adhesions around the BPH. So the scarification of the BPH around this treated area is very weak with this energy. I told you that we have new electrosurgical unit. These are the technical parameters, not so interesting for us, of these two devices. What for us is much more interesting, what's with the clinical application. Yes, we compared the clinical application of this plasma plus with a normal plasma, and what we saw is that we have with a plasma plus no blowout effect that we could have with very cold water and a high inflow of irrigation fluid. We have no multiple ignitions, never. So we need only one ignition of plasma and it works. We have an ignition in cell line in all cases, so we can ignite our loop and then go with the already activated plasma very slowly to take a very small slide. And the ignition is independent of the electrodes. And altogether with these measurements we can say that altogether the application with the ESG 401 is less, the application of energy is less than with the ESG 400. And we told about the role of the energy which was applied. And we tested how low the energy can be. And we took only for this test different wattages. And you see here from 120 to 50 watts, the ignition of plasma works. And if it becomes lower, then it does not work anymore. But the recommendation is never change the settings. So what we have in the comparison of these plasma and plasma plus, we have now a very fast ignition. It takes only 1/10 of the time of the former ESG, so less energy is applied. Fast resection are possible. Ignition is possible before touching the tissue, because of this way we have less danger to perforate and less extreme nerve reactions. The plasma works very stable, independent on temperature, dryness of the material and size and shape of the loop, we can have multiple electrodes working with the plasma, so we can use the best one for the treatment what we want to do. So altogether, TUR on cell line or plasma is safe and effective. We have weak reactions of nerves. We have no interactions with pacemakers. The TUR syndrome is very, very rare. That's why I did not discuss it here. We have the self-cleaning effects, very helpful. And the plasma enucleation and resection also reduces the intraoperative blood loss. And if we take the plasma plus, we have faster and more precise resections. We have the ignition in cell line, less applicated energy, and a very effective coagulation. That's about the basics, about the basic physical and clinical background information about the Plasma Plus. Thank you.
Hello everybody, I would like to talk now about how can we use the plasma for en-bloc resection of non-muscle invasive bladder cancer. And first, of course, we need to talk about the goal of TUR-B. The goal of TUR-B is to perform a complete resection. It means to resect all papillary lesion and also make correct diagnosis, which means that you need to see and also detect the carcinoma in situ. And you should also determine the depth of invasion in papillary lesion. To achieve that, you need to send a specimen to pathologists in adequate quality, and you need to receive the correct information from him or her. The TUR-B is a complex procedure. It should be performed systematically in individual steps. You can see it lower on the slide. There are several steps. Not all of them must be performed in all cases, but it is clearly in guidelines indicated when it should be performed. So my recommendation is do TUR-B systematically in these individual steps, and then don't forget the goal of the procedure. Very important question is the technique of resection. According to EU guidelines, you have two options, which is the resection in fraction. This is standard resection when you resect separately the exophytic part and the basic basal part of the tumor. But there is a new technique which is called the en-bloc resection, when we try to resect the tumor en bloc. And according to guidelines, you may decide which of techniques you are going to use, depending from your experience, location of the tumor, and so on. But even the en-bloc resection is maybe performed according to using the different equipment and using the different techniques. Again, according to the location of the tumor and your experience. On the left side, on the video, you may see the technique when we are using the incision electrode, the so-called Collins knife. You can use it in tumors which are well available, which are mostly on the base of the bladder, and it is necessary that you may find approach to the posterior aspect of the tumor to be able to use this technique. But you can see that the advantage is very precise demarcation of the tumor area. Here we are using the NBI for visualization of the tumor, and but disadvantages is that in the patients, for instance, with obturator kick, it may cause the perforation of the bladder. On the right side, you may see the en-bloc resection using the loop with retrograde technique. It is probably safer. You are using just very short kicks on the electric current source, so that the risk of the bladder perforation in this technique is very low, and it is usually safer, and it may be used even if you are not able to achieve the posterior aspect of the tumor. So this is the two basic techniques of en-bloc resection, which you may use. Of course, as I mentioned, you can decide according to your experience and according to the location and size of the tumor. To be able to see the lesion, it is important to have a good camera and also to use some advanced imaging techniques. There is well-known fluorescence cystoscopy, but you may have also some approaches using which are connected with some company equipment. It is, for instance, the narrowband imaging using with Olympus, or professional image enhancement system using by Storz. The Storz system is based most on processing of the signal of the image. I have experience with narrowband imaging. It is based on some filtration of the light, so that you use only wavelengths which are well absorbed by hemoglobin. So you increase the visibility of the tumor, which is hypervascularized. You of course need to understand how you may read the image of NBI. There is increased visibility of vascular fronts. This is this turtle egg-like structure that you see here in the view. There is a scattering of light by thickened mucosa. There are some poorly delineated capillaries beneath the thick mucosa, and you know that the tumor is connected by the thickness of the mucosa, even the carcinoma in situ. That's why we increase the visibility of the tumor lesion, and the advantage, of course, comparing to fluorescence cystoscopy is that you don't need any installation before. You just need to have equipment in your light source. Using the technique, you may increase the visibility of the tumor, or better demarcate the tumor areas. Here on the video, you may see that the tumor, in fact, the tumor area is much bigger with an NBI comparing to what you can see with white light. So that's why it is really useful if you may use it during your TUR-B. You also should select the best equipment. You may have different energy sources, the monopolar or bipolar. We prefer bipolar because of the more clear cut you achieve with that. But you may even do it with laser. You also should, using for instance, bipolar or plasma, you may use different loops, different shapes of loops, different sizes of loops according to technique you select. What I use is this Olympus technology, which is the light source, including the NBI. This is the equipment, and of course the plasma generator. This is the new one, the Plasma Plus. And what I always need concerning equipment, I use this endoscopic Mandron, which can help you to insert the endoscope under the vision, which is very safe, particularly in men. And then, as you can see, I use the different shapes and kinds of loops according to the procedure I'm going to perform. This is another example of en-bloc resection using plasma. Here, this is the tumor in not very favorable location. It is in the anterior bladder wall, but even here you may do very safe. Now you can see the view in narrowband imaging, and now we will start with the retrograde technique, the en-bloc resection. It is always very important to find first to demarcate the tumor area, and then start with to find a good level of resection to have enough muscle in the specimen, but without the bladder perforation, which is possible. As you can see here, the resection is deep enough. On the other hand, there is no real perforation in this moment, and we continue in this with this retrograde technique, so that within a few minutes we will achieve the complete resection of the tumor. But you may see that this is always a controlled surgery. We continue with a very short cuts. It is really very short activation of the electric, and so that this is always very controlled surgery. You can, in any second of the procedure, really control how deep you are, whether you really have muscle, at least visually muscle, and whether the resection is complete. And so this is a controlled surgery, which is of course advantage not only in complication rate, but also as a teaching process, so that you can very easily teach that in your young residents. Now we are nearly finished with the procedure. You may see we just finished the last few cuts. This will be the final one, and then I usually very carefully coagulate the basal part of the resection area and the surrounding mucosa. But you may see that this was really deep resection, but without the perforation. So, what about the oncological results of en-bloc resection? At least what was published, we published last year this consensus statement and some meta-analysis or systematic analysis of the literature concerning the recurrence rate. There has not been published the significant difference between the recurrence rate in standard TUR-B and in en-bloc technique. Concerning complication rate, which is another aspect of which must be evaluated in this procedure, we know that there was a lower, in published literature, lower rates of bladder perforation after en-bloc resection comparing to standard TUR-B. Can of course achieve a very nice specimen for pathologists. So this is an example. This is very favorable for good orientation in the specimen for pathologists, so that he can give you a lot of information, not only the presence of the detrusor muscle, but also the presence of the muscularis mucosae, the very precise staging of the tumor, and so on. So we believe that good specimen for pathologists is a very important advantage of en-bloc resection. We also have some data on that. You can see lower the paper published recently, which demonstrated that there was a higher chance to achieve, to have the muscle, muscularis propria, the detrusor muscle in the specimen in en-bloc resection comparing to standard TUR-B. Of course, as I showed you, this is very controlled surgery, so you can very precisely select the depth of resection. You, as I mentioned, you may also help pathologists to find the muscularis mucosae because of the good quality of the specimen. And it was published that the muscularis mucosae can be detected in most of cases using the En-bloc resection. So this is definitely the advantage. So you can achieve the information about T1 substaging, which is prognostically quite important information. Potentially in the future, we hope, using the En-bloc technique, we may be able to evaluate the margins, not only horizontal margins, but also vertical margins, similarly as we do it in any other oncologic surgery, right? Like radical prostatectomies, renal resections. This would be a big advantage, and some example how it may be done in the future was shown by these Japanese authors in Journal of Urology, the paper which was published this year. So, taking together, the advantages of En-bloc resection is that it adheres to the principles of oncologic surgery. Comparing to standard technique, we don't resect into the tumor. It is controlled surgery, so it is safe and easy for training. There is a better quality of the specimen sent to the pathologist. So we hope there are enough advantages to use technique if you have enough experience and if the tumor is a good case for En-bloc resection. There are some limitations, which is, as I mentioned, it is not feasible in all tumors based on their location or big size of the tumor. There is a problem with the retrieval of the specimen, so sometimes you need to use some hybrid technique. But generally, I believe that En-bloc resection should be used, and it can improve the quality how we manage the non-muscle invasive bladder cancer. Thank you very much for your participation, and it was a pleasure to be with you. Thank you very much.
The topic is to talk about plasma enucleation for prostatic hypertrophy. We talk about the surgical technique. This technique is an association of classic resection and mechanical enucleation. The protocol is to start at the level of the bladder neck. We start by the resection to the capsular layer. After, the second step is to do an incision of the mucosal at the level of the verruc from 7 o'clock to 11 o'clock, and then to start an enucleation. And I will show you some slides, and slowly you can try to do the enucleation until you will find the bladder neck mucosa at 11 o'clock. And then you can open the mucosa at this level and then finish the dissection of the enucleation of this lobe. After that, you have to go to do the resection of the anterior commissure from 11 o'clock to 1 o'clock. And then you can, with this, you will free, in fact, the lobe. And at the end, you have just to do the resection of the lobe. You do the same on the other side. And then you can send all the specimen to the pathology, and then place urethral stents with irrigation for about at least 2 days, and traction. This is the discussion for or against the plasma enucleation. What is great for this technique is that you have it's a classic resectoscope you have in your operative room, so that you don't need to have new instruments. It's a technique you know very well, but also what is great is that if at the time of the enucleation it's difficult, then if you don't succeed at the time of the enucleation, you can go on just with resection. That means that you can step by step improve your technique and slowly do better and better. Also, what is great is sometimes you can discover in the bladder, for example, a bladder tumor or stones, and then you can do the treatment of this at the same time. And it's fashion evolution. That means that now, when we talk about benign prostatic hypertrophy, most of the urologists are talking about enucleation, or with laser, or with mechanical enucleation, because it's a total treatment and you have less recurrence. And what I like very much is that we have the same results as a resection. I mean that we have no postoperative incontinence as we can have at the beginning of the experience with the laser. What is against this technique is that the surgery is really longer than the resection, but it's complete. So my question is, perhaps we have to move with morcellation of the specimen. Also, what is against is because of the technique. When it's difficult, you can stop and go on with the classic resection. That means that sometimes, if you are in a hurry, you won't go on with the enucleation because you will immediately go to the resection. So I mean that it's very important, if you want to start this technique, to take your time and to go on with the enucleation as much as possible to succeed. Perhaps it's a little bit more bleeding. You have a little bit more bleeding than with laser. You don't know. And also, the question is it possible to do this surgery with in the day surgery? It seems to be difficult in my opinion. So I prefer to keep the patient about 2 days in the clinic. I will show you some slides showing the different steps. You see here the verumontanum, the obstruction of the two lobes and the bladder neck. And so we will start at the first step is to start at the bladder neck, to do the resection and to find the posterior layer here. And when it's done, this is the first step, then you go at the level of the verruy, and then you will do the incision from 7 o'clock to 11 o'clock. You do the incision of the mucosa, and then you will do the same on the opposite side. And then slowly you will try to find the layer to start the enucleation. It's possible to spare some tissue at the level of the verruy to avoid to have a retrograde enucleation. But in this situation, you will let some benign tissue. Personally, I'm not doing this, but Professor Raßler, have a main experience of this technique, shows its possibility. So when you start, then you can use a double loop. You see this loop from Olympus. The first loop can lift the adenoma, and then the second loop can do the coagulation. You see very well the capsule with the vessels, and then you have to do the coagulation as much as possible to have a very good vision. When it's done, then you go to the 11 o'clock, to 12 o'clock position to do the anterior resection of the commissurotomy. And then when it's done, you will it will help to free totally the lobe. And then at the end, you have just to do the resection. This time is time consuming, and that's the discussion. Is it possible to do this time with a morcellation? Perhaps, we don't know. In my experience, I'm doing this surgery for the volume less than 100 grams. Above this, I prefer another technique because it's too long. So now I can show you at the end the video from. So this video is about 10 minutes. So I don't know if it's enough for you. So you see here the bladder neck. You see the bladder with obstructive bladder with there is no stones, but hypertrophy of the muscular part of the bladder with a lot of. And then the first steps is to do the resection of the bladder neck. So you see that for urologists, it's a classic movement. You know very well this movement. So that means that it's not a new surgery at this time. To do it very well, it's very important to have the liquid with physiologic serum heat, then it will help to do a better coagulation, and also with a great pressure to have a good vision. So you can have a instrument to have a good pressure on the bag, or you can also let the bag very high in the room, in the operative room. So you see the resection is with the plasma. Take times to have a good coagulation. And what is important here is to find the posterior layer. You see the bladder neck very well. And slowly we will prepare this end of the first steps. So you see very well the very, and now it's a second time. The second time is to start to do the incision of the mucosa, and so with section we will just do the incision, and immediately with coagulation we'll just have to do good coagulation. And then what you will use the tip of your instrument, of the resector, just to find the layer and to lift. In fact, to lift up. You see very well here the beginning of the enucleation, and immediately when you see some bleeding, you just do the coagulation to have a perfect vision of what you are doing. So it's very, very important to go on and to see very well. And you see the verrue, and we finish the incision, and then slowly, always being under the adenoma, you will just lift the adenome. You see perfectly now, and slowly you cut and just do the coagulation. And now we are at 9 o'clock, so we go on following the capsule, and slowly you can find the opening of this layer in between the capsule and the adenoma. If sometimes you have a bad layer, sometimes you can injure the capsule, no problem. So you just can go a little bit deeper or superficially, and you can see very well with experience slowly that you can see very well the good layer in between the adenoma and the capsule. You see very well now. We arrive at 10 o'clock here, and you see the coagulation, and again you push away the adenoma, and we will arrive now at the level of the bladder neck. And what we want now is to find this window at the level of the bladder neck, and we will open the mucosa. Now you will see. So you see probably in a few seconds. You see here a small piece of adenome, and you can push it away. And you see, it's a mechanical dissection. In fact, we use very, very few sections. Most of the time, it's only pushing. You see, now this is the opening of the mucosa at the level of the bladder neck, and now it's done. So, in fact, all the adenoma is on the right side is free, and now we will just finish the dissection, and we will go back at the level of the. This is the bladder neck, and now we'll go back at the level of the commissure, anterior commissure, and then we have just to do the resection of the lobe, which is totally free. So this time it can be long, but there is no bleeding because the adenoma is totally without any vascularization. So just take your time. So this time is great because when you are a urologist, you know very well how to do the resection. So the only difference here is to find again the posterior layer, but you will see that it's easy. So you just go and you just finish the dissection. You can if you have some small piece of prostate remain attached to the capsule, you can free them. And that's why I really like this technique, because it's a mechanical technique, anatomical technique. And you see now that on the right, everything is done. And this is a capsule perfectly. There is no more adenoma. And you will do exactly the same on the opposite side. And it's really an adenomectomy by endoscopy. So here we do exactly the same symmetrically on the right side now. When one side is done, the second side is easier because you have more place to work. But most of the time, one side is difficult. I'm left-hander, and for me, the right side is easier than the left. I don't know why. Perhaps the orientation of your hand, but. Just go on slowly, just to the good coagulation, to have a good vision always. You see that in this video, I'm not using the double loop, but you can use the double loop. In fact, it's really possible to do this enucleation with a simple loop. You see now again this enucleation. You see very well the capsule. And slowly you start to free the adenoma. So it takes about I think 15 Ks to start to be more confident. At the beginning it's difficult because you are not confident. You are not sure you can do it. You can injure a little bit, and you see again this hole in the bladder neck at 2 o'clock. That's great. You are the bladder neck. That means that the lobe is totally done. It's really an anatomic technique, and I think it's really a great option. It's different to the laser, but I like very much this technique. I learned this technique from Professor Raßler. I went in Leipzig 2 times, and I think it's a really great option because you can use your normal instrument and you can do a fashion technique with really an enucleation, much better than a simple resection because it's a total, and it gives very good functional results, the same results as you have with your resection. So for me, it's a really great option. And it's modern because it's a plasma, it's not monopolar, it's a bipolar plasma resection. And you will see now the end of the surgery when so at the end, what is very, very important is to do a perfect coagulation of the capsules to be sure that you have no bleeding, and to remove all the small piece of prostate to be sure that you won't have any obstruction. And you see now that the capsule is totally intact. So just take your time and just finish as well as possible your coagulation. And you see now the bladder neck, you see everything is done. So we have just to remove all the piece of prostate to the coagulation of the bladder neck, and it's how it's done. There is nothing more. This is very so. Professor Raßler used to inflate the balloon at 40 or 50 milliliters, and to place a small traction during 1 or 2 hours at the end of the surgery. I think it's a good idea. So my question is laser enucleation is better? I don't know, because some surgeons said that the energy given by the laser creates a good layer. Perhaps the hemostasis is better with a laser. We don't know. But one problem is the maturation of incontinence after laser at the beginning of the experience. There is a learning curve, and probably the apex dissection is difficult, probably more difficult with a laser. And probably you have also more mechanical lesion of the sphincter with the laser. That's why I prefer this aspect, because with the plasma, you can do the resection of the apex of the last part of the prostate close to the sphincter. Why the enucleation in plasma is not very well known, I don't know, because Professor Raßler have done 1,000 and 1,000 of cases. I don't know. I think we have to talk about this technique because it's a great technique. How to do after 100 of grams? Professor Raßler is able to do a total enucleation and then with a morcellator. I've never seen him do this, but it's possible. So the evolution could be mechanical enucleation and laser, or bipolar enucleation and morcellator. And Olympus is working on the thulium laser. Is it the new technique for the future? I don't know. And does it remain a place for adenomectomy by laparoscopic approach or robotic approach? I don't know. But personally, I'm doing robotic and laparoscopic adenomectomy above 100 grams. So in conclusion, I can say that this technique is for me really precise and anatomic, gives the same result as the TUR-P, and just simple for the learning curve compared to the laser.
Hello, my name's Jeremy Nettleton. I'm one of the consultant urologists in Cheltenham General Hospital, which is based in Gloucestershire in the United Kingdom. And I've been asked to talk about the pathway for a day case transurethral resection of the prostate and of the bladder as well. So the first question is it possible? So over the last 2 years, and we started this work prior to the pandemic, we asked the question, can we achieve day case transurethral resection of the prostate? At that stage, we weren't doing any, and we were already doing some resections of the bladder as a day case. And with no specific patient selection over 2 years, with a number of changes, we've gone to a 71% day case rate for both resections of the prostate, but also resections of the bladder. So it is possible. So how did we do this? Well, I think to answer this question, we have to look at the preoperative factors, the surgical factors, and also the postoperative factors. So a lot of achieving day case surgery is about education. And to that end, we changed our patient education and we changed their expectations. And in doing that, we've rewritten our patient literature. We've also updated our nurses about how to care for these patients. We haven't specifically selected to patients who are not for day case surgery. However, if patients live alone and there is no one who can stay with them, then we put them on the end of one of our operating lists and we accept that they will stay overnight. And that would not count as a day case, obviously. In addition to that, list management is important, and it is easier to achieve successful day case rates when you have an entire surgical list with resections of bladder and prostate only. This is because the whole team focuses on trying to achieve that goal, and the team becomes specialist in their key roles in achieving this. The anaesthesia is particularly important. We use a fast-acting spinal anaesthetic called prilocaine. This gives around 60 minutes of surgical resection time, and in our experience, no patients have needed extra anaesthesia. The benefit of this is that they recover quickly and their legs are working quickly in the post-operative period, allowing them to go home in an efficient manner. Obviously, with saline resection, then it is possible to do general anaesthesia as well, but our experience is the pain post-procedure is worse following general anaesthesia rather than a fast-acting spinal. In terms of changing the procedure for bladder resection, if needed, we do give paralysis, and routinely for both bladder and prostate resections, we give a tranexamic acid towards the end of the procedure when we're doing our hemostasis, and we also give 20 milligrams of furosemide, as this diuretic is good at allowing auto-irrigation. In terms of modifications for the surgery itself, 2 years ago we had some surgeons using a monopolar energy and some surgeons using second generation bipolar energy. And one of the big moves we've made is to the Olympus Plasma Plus system. This has allowed us to adapt our surgical treatment and have better hemostasis in theatre. With this more modern equipment, we adapt our resection to the tissue in front of us. So for tissue which doesn't tend to bleed, we can resect quite quickly, but for somebody who has a particular problem or perhaps has had to be resected on anticoagulation, then we adapt our resection to this. We also make use of the possibility of vaporizing tissue, and at the end of the procedure, we complete what I would regard as fastidious hemostasis. So the standard is crystal clear urine with no blood, and that is achievable for most patients. Because following surgery, we want to put in ideally a two-way catheter, and we favour a 20 French two-way Coloplast catheter, and we tend to put 20 to 30 millilitres in the balloon. The advantage of this particular catheter is it drains well, and if there were any residual chips or blood, the catheter can often cope with this. For some patients, they do need a little bit of irrigation, and our practice is to irrigate for 1 hour following surgery and reassess. If at that time we feel that they need to have continuous irrigation, then we make a decision to admit the patient and aim for discharge the following day. Quite a few patients who have irrigation go home with a three-way catheter, and our experience is that patients are quite happy to do this as long as they have a date for the removal of the catheter. So what do we do in that immediate post-op period? Well, because we tend to do these procedures on dedicated lists, the surgical team can review their patients after every case. And this means there's a constant dialogue between the nursing staff, patients and anaesthetist in deciding which patients are appropriate for day case discharge. In addition to this, because of the early mobilisation facilitated by the short-acting spinal anaesthetic, and also the early catheter education, we can get patients moving quicker than you may have done with a heavy spinal anaesthetic of the past. We aim to offer all of our patients an outpatient appointment for their removal of catheter before they leave the hospital. That means they're well informed about the pathway ahead and have a contact number if there should be any problems in the intervening period. So, of course, we have encountered problems along the way. As with all of these changes in practice, it's taken some time to encourage the whole department to move over. There was a significant investment in new equipment because our old legacy equipment was not Olympus. And we've also had to consider problems along the way. In 2021, so from January through to November, we've done around 205 resection of prostates, and 147 of these were day cases, giving us a day case rate of around 70%. So reattendance and readmission are important factors to consider, and we have had around 20 reattendances to the hospital in the 30 days following surgery. Of those patients, only 3 have been readmitted, giving us a readmission rate of around 1.3%. Most of the problems patients have are blocked catheters, and only 1 patient was readmitted with bleeding, needing to go back to theatre. Thanks very much for taking the time to listening to this short presentation, and I hope you enjoy the panel discussion. Thank you very much.
Dear colleagues, welcome to our discussion round about the Plasma Plus and the use of Plasma Plus in the treatment of BPHs and non-muscle invasive bladder cancers. And I welcome you, Professor Babjuk, Dr. Mandron, and Dr. Nettleton. And we start with the first question to ask, please, Professor Babjuk, what are the indications and the contraindications or the limitations of plasma resection of in en-bloc technique?
Okay, first, thank you very much for the invitation. Good afternoon to everybody. It's a pleasure to be here. Concerning the limitation of en-bloc techniques, I don't think we can define any specific limitation because it depends from the experience of the surgeon. And I don't believe, and I believe that it is possible to perform en-bloc resection of if you have good enough experience and good equipment to do en-bloc resection in every tumor which is possible radically or really remove with standard TUR-B. So there is, if you have enough experience, you can use the en-bloc technique whenever inside the bladder to each resectable tumor. Limitation, of course, is the retrieval of the tissue. So if the tumor is large, then you probably need to use some hybrid technique when you resect the exophytic part of the tumor in standard way and use en-bloc of the basal part of the lesion.
Thank you. And how was it when you started with Plasma Plus? Did you see differences between using Plasma and Plasma Plus? Did you see any advantages or changed your modified your technique?
No, I don't think that I particularly modify the technique, but my experience is that it works better. So the incision is more precise and more effective.
Okay. What's with the localization of the tumors? Do you use PDD or NBI for the localization?
I think the visibility of the lesion is very important for any kind of surgery, and I use NBI routinely in every patient, and the PDD in selected cases when I expect carcinoma in situ or in really individual cases because it is too expensive in our condition.
Okay, and for many colleagues, it's very important because the en-bloc resection is not so common till now in all hospitals. How long is your learning curve?
It again depends from your experience with endoscopic surgery. So I think I did my first case without any problem and without special learning before. So I think it is possible if you have enough experience, you can start with en-bloc resection, and the learning curve is not particularly long. So it is difficult to specify that, but of course you need to start with tumors in easier locations, which is in the lower part of the bladder, on the trigone or behind the trigone, and not with particularly large tumors. But as I said, if you have enough experience with endoscopic surgery, it will probably be not a big problem for you.
I think so. Thank you first for your answer of the questions, and we want to continue our discussion maybe with the BPH enucleating technique. Dr. Mandron, what's your experiences with the enucleation and plasma? And is there a limitation for you according to the volume of the BPH, or what's your strategy?
So, hello everybody,
hello.
And I'm very pleased to be with you to share this this table. I must say that I'm doing this enucleation with plasma for now more than 5 years. I came in Leipzig to learn the technique with you 2 times, with Professor Raßler, and I must say that it's different from the en-bloc resection for the bladder tumor. It's more difficult at the beginning. Yes, when you are a urologist, you know how to do a resection, but it's not the same to do the enucleation. So right now, the limit for me is 100 grams. Above 100 grams, I prefer to do adenomectomy. I'm doing it by laparoscopy or by robot, because I'm not able right now to do a total enucleation and a morcellation. That's my vision.
Thank you very much. Every time if we do an enucleation of the BPH, we have to compare with the laser surgeons, and they have some strategies: 2-lobe, 3-lobe, 1-lobe enucleation technique. And one difference is, how do we handle the middle lobe? What's your strategy? Do you resect the middle lobe, or do you enucleate the middle lobe, or what are you doing?
I'm starting always by the median lobe, and I'm doing a resection for the median lobe to prepare very well the posterior layer, and to keep to see very well the verruc, and to have all this posterior aspect, and then it gives some space to be able to enucleate the lateral lobe. So in my experience, I'm not doing enucleation for the median lobe. When I'm doing laser, I start by enucleation. It's different. But when I'm doing plasma, I'm doing a resection of the median lobe.
Yes, I totally agree with you, because I think we have a very excellent multifunctional tool with a loop, and it's we are not only able to give the energy forward or straight on. We can resect, we can morcellate, we can enucleate. So we should use it, of course. What's with the postoperative urge symptoms in your cases? Because our theory is bipolar current, even the plasma plus, should decrease the postoperative urge. Can you follow that?
I'm totally agree. I use, because now I'm 57 years old, I used to ask urinary test 2 months or 3 months after the resection before. And when I was seeing the patient postoperatively, I was seeing after resection a lot of microscopic hematuria and leukocyturia. When you are doing plasma, that's totally different. The exam is normal. You have no more, the cicatrization is much more quick, and then they have no urgency, no pollakiuria. So I think for me, the functional results are much better with enucleation and much quicker to recover good functional results.
Okay. One of the disadvantages of this technique is that you cannot see the tip of the sheath, of course, during the enucleation. And so it is recommended in some cases, or in all cases, to use an enucleation loop. Now we have a newer one. Did you ever use it? And what's your experience with the enucleation loop?
I tried both. In fact, most of the time I'm just doing with the tip of the instrument and with a normal simple loop. But I work with a double loop, and it's not so bad, but it's more difficult to do the resection. So when you improve your skill, slowly you move to the simple loop, because it's quicker. And really, I think it's important at the beginning of your experience to have the double loop, but slowly you can move only with a simple loop. What I must say that I work also with a simple loop, but much more hard, because sometimes you can have a deformation of the loop, because when you push with the instrument. So sometimes you can use another simple loop, which is more solid, in fact.
Okay. Yes. Yes, that's also my experiences. And what's with the postoperative retrograde ejaculation? Do you have do you follow an ejaculation preserving technique, or does the success rate is too low? What's your experience?
Right now, I can't say that I have a good result on this part of I try to preserve the space surrounding the verruc, but sometimes have an undergrad ejaculation, but it's not always. So now,
Yes.
right now, I can't say to my patient, you will have a normal ejaculation. I can't.
Yeah.
So I think I have to learn again, and perhaps we don't know exactly everything concerning the ejaculation.
And the last question, just like to Professor Babjuk, what was your personal learning curve? How many cases were necessary to operate to feel familiar with this technique?
In fact, I had two steps. I started 6 years ago. I've done about 15. It was the first experience. But the problem, the advantage and the problem of this technique is that when it's difficult, you can stop and you can do resection. So 6 years ago, when I was in difficulty with the enucleation, I stopped and I redo resection. And finally, I came back to see you last year, and then I have a new motivation. And now I'm totally confident with the enucleation, and now it's okay. So I must say that it will depend on your motivation. You have to go on with the enucleation, because the disadvantage is that you have also the technique to do the resection. It's different from the laser. When you have the laser, you have to do enucleation. With this plasma enucleation, you can do resection if you are not able to go on. So for me, I will say between 15 to 30 cases to start to be confident, to know the layers, the different layer, and to go on with the technique.
Thank you very much for this question, for this answer, because I think maybe somebody will need some more, but it is learnable, and you can learn it, and you can be successful with this technique very fast. Okay, thank you very much. And so we come to Dr. Nettleton, and that's a completely different topic, because it's quite interesting for us. If we meet with sometimes French, sometimes British urologists, every time they ask, can it be performed as a day surgery? I think there is a reason, because of the health system of the country. Why do you do these procedures as day surgery, and what's the background to understand for us?
So I guess thank you very much for the opportunity to talk. I agree, the health system is very keen on keeping patients out of the hospital in the UK. And the thing which really accelerated this program was COVID. We had just started 4 or 5 months before COVID came, and we realized we could look after these patients and keep the hospital free of beds for other patients. So that's sort of the background. And we went on a journey from monopolar before I started to old-fashioned bipolar to plasma plus. And the bottom line is it's possible, it's safe, and patients like it. They don't want to be in hospital. So it's good. The difficulty is picking and working out who can go home and who can't. And so that's the complexity, really. The technique, there's some modifications which I spoke about in my presentation, extra drugs like tranexamic acid and frusemide for auto-irrigation. So there are modifications, but it's entirely possible, and it saves hundreds of beds every year in a health system which hasn't got beds to spare.
Okay. But everybody who performs TUR-B or P knows there has a certain amount of post-operative bleedings or post-operative problems. And in these cases, you have to make a re-intervention to look what's bleeding and not to release the patient with a bleeding bladder or so. How big is your re-intervention rate with these patients?
So our re-intervention rate's about 0.4%. So one patient in the 146 day case patients had a re-intervention going back to theatre. The commonest problem is a catheter problem. So a retained chip or a clot, and that's about 12%. So that's quite a lot.
Okay.
But all of those patients come in, reattend, and go home again. A lot of this is finding the right catheters. It sounds like a crazy simple problem, but a good catheter for this problem is essential. And you can put a 3-way catheter in. We have now moved to 2-way catheters. But the key thing is, if you're going to put in a big catheter, is the patients need to know when it's coming out. So in our health system, that's another problem. So you're moving things down the line, but a nice, large 20 French silicone catheter, and usually they're fine.
Okay, thank you. And for us, difficult for us is to organize the post-operative care for the patient. How is it organized in your hospital or in your country for these day surgery patients?
Yeah, so this is not standard in the UK. So not everybody is doing this. Is the first thing. But what we tend to try and do is put patients on a list of resections, so either bladder or prostate, without other major surgery, because that is a distraction otherwise from doing day case surgery and good quality bladder and prostate surgery, in my view. So we've moved to have most patients on dedicated lists where we might do 7 resections in a day. So it's quite intense. For the post-operative care, we arrange for our nurses to see the patients ideally 24 to 48 hours after surgery as an outpatient appointment. And then they have the removal of catheter, and then they have a telephone review at 3 months.
Okay, thank you. And do you think COVID will force us, to do all these procedures in a day surgery in future?
Well, I can't tell what's going to happen with the pandemic, but it depends on your health system. If you've got the beds available, then the lowest risk thing is to keep patients in. But it's expensive, and it's safe to do it as a day case.
Okay. At the end, could you repeat again what are the indications for day surgery, BPH, bladder tumors? I can understand BPH. How much shall it be, or what's the maximum of volume, or whatever?
So we don't, at the time of prior to surgery, we don't plan to not send everybody home. So everybody is planned as a day case, and then we accept that about 1 patient per list will be admitted, because it's very hard to anticipate whether it's going to be your large resection or your moderate size resection, which is going to have a problem. You just can't tell sometimes from an MRI or an ultrasound or a rectal examination. So you can't guess. And so we've had 90-year-olds go home. You just, the more experience you get, the more accepting you are that actually most patients have a very good experience, and you just have planned to have 1 bed spare for the list, and then it works well.
I think that there's no solid parameter to divide the patients in day surgery or in patients without any problems intraoperatively. That's also our aim. Okay, thank you very much.
We are constantly improving our surgical training. This is why we need you to participate in our AIS core initiative to rate the quality of our content. You can rate our content by giving it a score from 0 to 10. 0 meaning not useful, and 10 meaning extremely useful. You can tell us if this is a good content to share. Thank you for your commitment to the democratization of surgical training.